Hi, thank you for inviting me to share my research journey and findings with the DOHAT community. I do not have anything to disclose. I would like to start by acknowledging my granting agencies, Dr. Noordin Mohammed, my collaborators, my research team, volunteers, study participants, my PhD students, and my university, the Aga Khan University. So, in the next 30 minutes, I would be talking about the status of obesity and non communicable diseases in Pakistan. I will try to provide some evidences for adiposopathy and its effect on health and disease in terms of metabolites, visceral fat, hormonal and biomarker variations. I will also talk about the effect of these biomarkers in breast milk and gestational diabetes, resulting in preconceptional exposure to epigenetic changes and its effect on blood glucose control. Lastly, I will be talking about some of the issues and limitations faced during these studies, as well as my future direction. I'll start the journey by sharing this image. This is known as the YY paradox, where you see two gentlemen, Dr. Yajnik and Dr. Yudkin, who share similar BMIs. However, if you look closely, you would appreciate that the one gentleman looks thinner than the other. Dr. Yashnik, for instance, weighed less than 5 pounds at birth, but surprisingly, now he has a similar body mass index. Now, if you look at their body fat percentage, you would be surprised to see that Dr. Yashnik had a whopping 21% of body fat, whereas Dr. Yudkin has only 9%. This finding attributed towards the accumulation of high body fat in South Asian population at a lower BMI in comparison to their Caucasian counterparts. That almost 27% of adults in Pakistan have diabetes, while 15% suffer from gestational diabetes. However, these figures are alarming, keeping in mind the low socioeconomic status of Pakistan and the limited healthcare facilities available to the general masses. Therefore, the all-cause mortality and morbidity related to both diabetes, gestational diabetes, and obesity are way higher in our population as compared to other parts of the world. This links to the fetal origins hypothesis or the thrifty gene hypothesis, which explains the difference in adipocyte behavior in Caucasians and South Asians. You can see here that the Caucasians, if they consume high energy, their adipose tissue undergoes hyperplasia versus South Asians whose adipose tissues undergo hypertrophy. In addition to that, South Asians are genetically predisposed to store fat in the abdominal area, specifically in the liver and other viscera, as compared to no visceral fat in the Caucasian population. It would be safe to say that the perinatal nutrition environment programs the metabolic phenotypes in South Asian adults, whether they would be metabolically healthy or whether they will be metabolically unhealthy, irrespective of the body weight they have or irrespective of the body mass index that they have. Also, the prevalence of overt maternal diabetes is associated with the incidence of diabetes in an offspring, which is translated to almost 35% when only one parent has T2DM in comparison to 10% of general population. Adipose tissue has unfolded as a proactive endocrine organ that influences systemic function, precisely stemming from active release of cocktail of biochemical molecules, which is commonly known as adipokines. Here we look at a healthy white adipose tissue. It is composed of adipocytes, the yellow colors, adipose tissue macrophages, pre-adipocytes or fibroblasts, and a blood vessel. In cases when the white adipose tissues expands or hypertrophies in South Asian population, three major events start to happen. They become larger, resulting in lack of blood flow and tissue hypoxia. The fibroblast or the pre-adipocytes are activated to convert into mature white adipose tissues. The macrophages are activated to become pro-inflammatory and they become inflamed, thus resulting in release of certain biomarkers, which is known as adipokines. This subclinical inflammation causes adiposopathy, and the physiological effect of this adiposopathy is related to defects in energy homeostasis, lipid metabolism, insulin insensitivity, and inflammation. All these effects leads to increased risk in cardiovascular disorders, non-alcoholic fatty liver disease, and insulin resistance. So the biggest question for me to solve at the beginning was, what is the status of body fat percent in our surroundings? So I started to seek answers, and we reported a very interesting finding that the BMI scale is actually not a true indicator of obesity or overweight in our population. As you can see that BMI wrongly or incorrectly classified individuals as normal weight, whereas their body fat percentage was higher and they should have been classified as overweight individuals. This was mostly seen in men, which again was a little alarming because if you look at the trends or the number of premature deaths that happen because of the non-communicable diseases is way higher in men in Pakistan, which is currently estimated by WHO. Thus, the next question was, what is the pathophysiological role of adiposopathy in developing DM or METs? As in most cases and most studies, undernutrition is highlighted as a risk factor for South Asian population. But on the contrary, we found that it was not undernutrition, but increase in the deposition of body fat. So what is true? What's the true status? Is our genetic profile similar to genetic profiles reported in the genome-wide association studies? Are we unique? Are there any unique biomarkers or genetic traits that we can find out? And then what is the situation and what's the difference in pregnancy, preconceptual health, and what are the effects of all of these after birth as well? So the first step for me was to recruit metabolic syndrome patients in 4 different phenotypes as per the NCEP guidelines. I recruited obese but healthy, obese but unhealthy, normal weight but healthy, and normal weight but unhealthy individuals. And we found out that almost 27% of normal weight individuals had fatty liver disease, and almost 18% were diagnosed as having metabolic syndrome. Having fatty liver is now considered as a huge risk of developing diabetes and cardiovascular disorders. Yet, none of these normal weight individuals complained of any sign or symptoms of having either fatty liver or diabetes. So this led my group to search for a screening biomarker that can be easily detected and can predict risk of diabetes or cardiovascular diseases even before the onset of symptoms. We identified Cameron as an independent marker that was related to adipocyte metabolism and hyperglycemia. Cameron is an adipokine which regulates both inflammation and adipose tissue metabolism. We also identified that the certain biomarkers such as test neutron and aspartin, which are related in maintaining satiety, were decreased in patients who tested positive for metabolic syndrome. We conducted a cross-section study where we implemented oral glucose tolerance test to individuals and measured adipokine levels. We were able to screen more than 30% individuals visiting public and private sector hospitals as newly diagnosed diabetes without any sign or symptoms. We then calculated the cutoff of 13.7 of Cameron, which was able to discriminate subjects with impaired glucose levels with 91% sensitivity and 96% specificity. Therefore, we suggested that elevated serum Cameron levels above this cutoff can act as a surrogate of impairment in glucose metabolism in obese individuals. Our group has so far worked to identify such subtle differences among the metabolically healthy and unhealthy phenotypes and have successfully narrowed down to specific adipokines and cytokines. These include camerin, leptin, renalase, and other metabolomics involved in lipid metabolism. All these factors, either individually or in conjunction with environmental or lifestyle patterns, were found to have a potential to predispose individuals with an elevated risk for developing type 2 diabetes and or obesity. This is particularly important for individuals who did not fit phenotypic profiles or who do not yet present with signs and symptoms of diabetes. More so, we also found a similar pattern in pregnancy-induced diabetes. So next we move to validate our findings in pregnancy and in relation to fetal maternal health, where we recruited pregnant females according to the IAD-PSG criteria as normal glucose tolerant and gestational diabetics. We followed them up to 6 to 24 months postpartum, and we found that the levels of adipokine camerin and leptin were 7 and 5 folds higher in gestational diabetic females as compared to controls. The adipokine showed a strong correlation with fasting blood glucose levels, homeostasis model assessment of insulin resistance, and the fetal weight at birth. Raised Cameron levels again was able to identify 96% cases with a cutoff of more than 15.49 nanogram per ml in pregnancy. We further analyzed the fasting blood glucose levels at different points during pregnancy as well as postpartum. Here you can see the levels at 24-28 weeks, which clearly demarcates our two groups of normal glucose tolerant versus gestational diabetes. When we followed them at 6 weeks postpartum, you can see that most of the gestational diabetic patients had resolved to their normal glucose levels or had restored their glucose homeostasis. But when we followed them at the 2-year mark, we could clearly identify that there were some individuals whose blood glucose level even higher than the levels under pregnancy duration. And thus, these were the individuals that were diagnosed as having developed type 2 diabetes in addition to having T2DM. Despite the facts that we had sent them constant reminders during the follow-up between the pregnancy duration, delivery duration till the 2 years, out of almost 500 individuals that we had recruited, only 27 individuals came for screening or did regular screening for their glucose levels. Out of those, 11 developed type 2 diabetes and 3 were diagnosed as pre-diabetics. The percentage of people developing type 2 diabetes after GDM was way higher. And when we asked these individuals who did not show up for screening or did not follow up on screening, why, what was the reason for not following up, they said that it's common understanding that it's just related to pregnancy and as soon as I've delivered, everything would go back to normal. Or they thought that even if I get tested regularly, I would be falsely diagnosed as having type 2 diabetes. And the last and the most common finding was that I am preoccupied with my baby and therefore I cannot come for the testing. So the next question for us was to identify, do these biomarkers remain elevated postpartum? Are they released in breast milk or not? Therefore, we aim to evaluate the levels of camerin, irisin, and sterol binding protein levels in serum, colostrum, and mature breast milk in women with and without gestation diabetes. We identified that the serum camerin level at 28 weeks of gestation was higher in gestation diabetics as compared to controls. The trend remained same at the 6th-week postpartum period. When we compared the colostrum and the breast milk levels, higher camerin concentration was observed in cases versus controls. An interesting finding was that camerin level dropped in the breast milk samples at 6 weeks postpartum for controls, but still remained elevated for the gestational diabetic subjects. Sterol binding protein showed a trend of low serum levels in gestation diabetics. However, they were undetectable in colostrum and mature breast milk. Further, since this was related to lipid profile and its control in normal individuals as well as in pregnancy, the low levels of SREBP1 did not have any association with the lipid profile or the status of lipid during pregnancy or post-pregnancy. We also identified lower levels of irisin, which was seen in serum, colostrum, and mature breast milk of gestation diabetic females. Low irisin level may predispose individuals for insulin resistance and white adipose tissue hypertrophy and thus development of gestation diabetes. Furthermore, lower levels continue to be secreted in the breast milk, which could continue as a stressor for infant as long as the breastfeeding is continued. However, we think that still further studies are required to identify the mechanistic relationship between these specific biomarkers in gestation diabetes as well as postnatal, and maybe follow up of those babies born to gestation diabetics would give us a better indication of if they develop early diabetes or early obesity versus normal diabetic control. Next, we looked at the genetic profile in GDM, and my group has reported several susceptible markers specific to local populations, such as KCNQ1, Vaspin, Gamarin, and Renalase, and their specific polymorphisms that predispose to hyperglycemia, high birth weight, and high blood glucose levels in newborns. Up till now, all arrows were pointing to altered glucose homeostasis in our population. And we know that the degree of glycation increases the epigenetic changes, which is the study of heritable mechanisms. Therefore, we looked at another angle, which is the production of advanced glycation end products. So this advanced glycation end product is a byproduct during the autooxidative pathway of our metabolism. The most common advanced glycation end product is the HbA1c, which we all know of, which is an earlier stage of age, as we call it. However, if early ages convert to late ages, this becomes an irreversible condition. And this is the point where epigenetic modifications or gene silencing or gene reprogramming starts to happen. And this is where if the constant exposure, either preconceptual or during the gestation period happens, then this irreversible effect happens to be translated into the babies as well. Another interesting finding was that the ages are not only produced during the biochemical pathway, but they can also be ingested by exogenous mechanism. That is, the junk or the processed food that the individual eats also increases the quantity or the concentration of the irreversible or the late ages within the body. So what do these ages actually do? These ages have a higher affinity to attach to albumin, to low density lipoproteins, to immunoglobulins, activate macrophages, specifically in the capillary endothelium and the subendothelium. Ages come and attach to the collagen fibers, causing increased permeability, causes protein accumulation and thickening of the basement membrane, activation of immunoglobulins, complement system, and activating inflammation. They also like to trap low-density lipoproteins within the endothelium and causes atherosclerosis, activation of reactive oxidant species, uptake of ages by the macrophages leads to their partial degradation, and then this causes activation of tumor necrotic factor and other cytokines release, which is also increased in the release of inflammatory adipokines. All of these things can then affect the organ system, such as the brain, the kidney, the heart, and the eye. Next, we embarked on epigenetic studies and identified specific genes that had a potential of being deranged or methylated or silenced by their persistent hyperglycemia or the presence of advanced glycation end products within. So we selected genes which affected emotional eating and eating disorders, such as brain-derived neurotropic factor, which helps in maintaining the insulin sensitivity. The protective against obesity gene, which is known as the nicotinamide phosphoribosyltransferase or NAMPT. This is involved in the cellular redox reactions. The body mass index qualitative trait locus genes, such as INSIG, that is insulin-induced gene, or the FAT4, which is the atypical cadherin 4 gene, or the FTO gene. All of these genes are related with activity of insulin and leptin, as well as expression or regulation of adipose tissue metabolism, or they are related with cell growth or cellular polarity. Hyperphagia, appetite, and satiety related gene, that is pro-opiomelanocortin or POMC. This gene regulates insulin release and satiety. The defective beta cell development genes, such as insulin-like growth factor, IGF-2, or NeuroD1, which is neuronal differentiation 1. Both of these genes regulate the formation of endocrine isle cells and insulin gene expression in itself. Then the genes related to impairment of insulin signaling, which is specific to organ resistance, such as chemarin, which is related to adipogenesis and maintenance of insulin sensitivity within that, and the melanocortin receptor 1b, which is associated with neurobiological functions of melatonin in conjunction with POMC, leptin pathway, and insulin sensitivity. Last but not least, we looked at the adipose tissue metabolism controlling gene known as the human fibronectin type 3 domain, or FNDC. This gene is highly enriched in liver, brain tissue, and adipocytes, and this encodes protein which helps muscles during exercise and which helps them to reabsorb insulin. And thus maintain the insulin sensitivity, and this also activates the formation of brown adipose tissue. So for this study, we recruited both gestation diabetic females as well as normal glucose tolerant females. We recruited them from the start of conception by the time they came to the gynecologist clinic, and then we followed them up till 2 years. Again, we took their blood samples as well as the cord blood samples at delivery, and then the baby sample at the time of 6 weeks postpartum when they came for their follow-up studies. I'm going to show you a few genes that were significantly associated specifically with derangement in the random blood glucose levels in both mothers as well as the babies. These genes such as chemarin, FET4, NAMPT, FNDC, and MTNR1B, these were methylated or unmethylated in respective to the gene silencing. And once these genes were silenced in the mothers who were suffering from gestation diabetes, this translated to the derangement of these genes and their genetic functions in the newborn babies as well. Despite the fact that we could not find any difference at the time of birth in these babies in terms of the weight, in terms of the point of care blood glucose level, but at 6 weeks postpartum, we were able to see that the random blood glucose level was still variable in these babies, and of course in their mothers as well. Or these hyperglycemic effects happening during pregnancy has led to gene silencing of these specific 5 genes, which resulted in development of insulin resistance and deviation in random blood glucose homeostasis in both mothers as well as babies born to gestation diabetic mothers. Is predisposing these babies to develop diabetes at an early age and maybe develop non-communicable diseases at an early age as well. In order to confirm our finding, we ran a machine learning algorithm in adult samples. And the machine learning algorithm identified similar genes, that these were the 5 genes which were significantly associated with blood glucose abnormalities in adult samples as well. If we identify these screening tools, these biomarkers, or these epigenetic changes in an individual at an earlier stage without them showing signs and symptoms of developing diabetes or hyperglycemia, we could safely provide them lifestyle modification. We can guide them in terms of nutritional supplementation or weight loss or fat loss management. And of course, this would then lead to them not developing the disorder at earlier age and maybe prolonging their quality of life as well. We then calculated the CVD risk score using Q-risk calculator. This score tells us the probability of each individual developing a cardiovascular disorder, such as an MI or a stroke, in the next 10 years or so. For the METS positive individuals, almost 19% people who had the genetic mutation or the methylation status were ranked as intermediate risk, whereas almost 71% with those mutations were ranked as high CVD risk. But the alarming fact was that people who were categorized as metabolic syndrome negative individuals or normal weight individuals with the mutation or methylation changes on these specific genes was still 25% and 29% put on intermediate and high CVD risk. This indicates the need for therapeutic lifestyle intervention and a drug need in these subjects, in addition to early screening and having the research data in hand. We then wondered if this knowledge about fetal programming and obesity status and methylation and its effect on health and disease are understood by the general public or even the healthcare providers itself. So we conducted a CAP study, and to our surprise, very few individuals had heard about fetal programming or about this phenomena either. Further, there was a misconception that mostly mother's health affects the offspring health, and father's health has no effect or very limited effect on the baby. Therefore, if the father has diabetes or even if the father is obese, it will not have a detrimental effect on the baby itself, which is contrary to the fetal origins of health and disease hypothesis. Further, we also inquired if they knew that childhood obesity is an issue in Pakistan, and most people said no, it's not. And in terms of having large for gestation at babies born or overweight babies, they said that's the sign of a health in its own, and it's just baby fat, and it will go away on its own. So based on these findings, I have moved for a curriculum reform here in our university, and I've implemented the concept of epigenetics and fetal programming in our undergraduate as well as in our master's and PhD curriculum, so that people have true understanding and information about what this is all about, fetal programming and epigenetics. And then therefore, by just creating knowledge and awareness, we can at least try to decrease the burden of disorder. So during this whole journey, we faced multiple issues and had some limitations, mostly pertaining to funding limitations, a failure of participants to follow up despite multiple reminders, reluctance in getting tested. So now what I am doing, or my team is actually doing, is now we know that these genes have methylation potential, and we as a population are at risk of developing methylation or gene silencing for these specific markers. So what I'm doing is now we've implemented a mobile health intervention to reduce these epigenetic signatures of specific advanced glycation end products in adult population at this moment, specifically the adolescents. Thank you very much.
Thank you, Sadia, for an excellent presentation. Any questions for Sadia, Fatima? Please note that the presentation will be made available on the International Society for the Doha website. So I would encourage all the participants to join the International Society for the Doha. So let me see. All right. So Sadia, we have a question for you. Do you have any measurements before pregnancy?
Oh, very good question. So at the start of pregnancy, yes, we did, but unfortunately we couldn't get measurements before pregnancy because that was one of our limitations. But we did had at the start of pregnancy, and then we follow them up till they develop gestational diabetes or not, and then we follow them later on. So if you say that the first time they visited the OB-GYN clinic at, let's say, 12 to 15 weeks of gestation, and that was our 0 point or day 0 for us. And then at 2 years postpartum, that was our last day of evaluation. But no, we could not do that before pregnancy. But for the current study that I'm doing, we are recruiting adolescents, which are at this moment unmarried, and then we'll have aim to follow them up later on, and then maybe see what happens at that end.
Okay. Any questions for Sadia? Meanwhile, Sadia, I have 1 or 2 questions for you. So in the methylation studies, is there a way that these changes can be reversed or prevented?
Interesting question, Dr. Noor. So yes, this was something that we also had in mind. Fine, we've identified that methylation is happening. We know that environmental changes cause it, but is it possible that we reverse the environmental change, and is it possible that it goes back? So I did a very small pilot study with healthy medical students. We did their methylation status and measured the methylation in percentages for a couple of genes, for example, camerin, andesitrin, and nisfatin. These are related to hyperglycemia as well as satiety control. Then we put them on a 6-week lifestyle intervention when they had to actually abstain from all the processed food in their life. So no energy drinks, no Coca-Colas, no bakery items or anything like that. And then we tried to repeat that after 6 weeks. So we found that there was a slight decrease in the methylation potential of those genes that were causing hyperglycemia or are susceptible of causing hyperglycemia. But those changes were very, very less in comparison because it was just a 6-week study. So the current one that we are doing is based on the findings of that pilot. And this time we are doing a 6 months intervention. And we are giving these subjects proper lifestyle modification in terms of diet as well as exercise. And now we have a day 0 sample. So that is before, and then we are doing a follow-up, and hopefully we'll get some good results in that case. So if we are successful, then yes, very simple measures, such as going back to, doing simple 15 minutes walk a day is something that is as simple as reducing or reversing the epigenetic changes. Yeah.
Thank you, Sadia. Sadia, we have the comment from earlier participant, Chitrajan Vyajnik, who actually asked the question regarding measurements before pregnancy. And what he's suggesting is that your findings will be present from preconceptional time. So diagnosing GDM in pregnancy is too late. So it's the periconceptional epigenetic reprogramming, is over within 72 hours of conception. So that's the comment we have from him.
Absolutely. Thank you so much. That's a very nice thing. And hopefully next time when I'm recruiting samples, I'll make sure that we start preconception and then follow them forward. Yeah. So that will give a holistic view of what we found.
All right. Okay, Sadia, you mentioned the term newly diagnosed diabetes in one of your studies. So what was the criteria for these patients?
Right. So that was the study that we did in adults from 18 years onwards. What we did was we asked them to give us blood sample for HbA1c only. And we try to identify, and we ask the questionnaire that do they have symptoms related to diabetes or not, and family history and all of those things. Surprisingly, some of the participants did not have any symptom, but their HbA1c was deranged and it was in the diabetic zone. And some of them were in the intermediate or pre-diabetic state. So they were then followed up. They were actually then referred to diabetologist, and they were diagnosed as newly onset diabetes without having any symptoms yet present. So these were the people that we termed as newly diagnosed diabetics.
Okay, all right. And the comment from Yagnik is that thank you for starting the talk with the YY paradox, which you duly mentioned in the beginning of your presentation, and well done for that.
So that's actually the thing that motivated me to do all of this research. So I'm thankful for the YY paradox. Yeah.
Great. Satya, what was the BMI values you actually used to classify obesity in our population? Or what BMI values you?
Yeah, so these were the South Asian cutoffs, which are proposed by WHO for South Asian specifically. It's a stricter criteria for us versus the Caucasian. So it says that if a person is between 18 to 22, that's considered as normal weight. but between 22 to 24.9 or maybe now 25 is overweight, and anyone above 25 kgs per meter square is now considered as obese, and then the degrees move on. But if you compare it to the Caucasians, you see that 30 and above is considered as an obese individual for them. So because of the body fat content, we have a stricter criteria for us.
Okay. You mentioned about some biomarkers in the breast milk. You know, there's a sustained release of how that could have an influence on fetal health and fetal programming in the long run. How do you see that happening?
Right. If we talk about, let's say, Cameron only, which programs the adipose tissue metabolism, programs how many adipose tissue there would be, how big they would get, and then, you know, all the release of inflammatory cytokines. So that was the one that was increased during the pregnancy period. It's released from the placenta as well, but that gets exaggerated if the person has gestation diabetes too. And then that is sustained, it's released continuously in the colostrum as well as breast milk. So when we compared the levels of this biomarker in breast milk, and then we compared it between the two groups that we had, we found differences there. So people who were normal glucose tolerant had a lesser level or minimum level in the breast milk, whereas people with gestation diabetic still had a persistently high level there. And when we compared the birth weight versus the weight at 6 weeks and then weight at 2 years of the babies who were continuously breastfed for both the groups, we found that babies who were breastfed by gestation diabetic mothers who had a higher Cameron level had a higher body fat and a higher body weight because of this versus the normal glycemic babies born to them. So this is what we the link which we proposed was that if there is persistent release of Cameron there in the breast milk, then that is also causing after birth programming too of, you know, exaggerating the deposition of fat, or maybe visceral fat is being deposited. That's why they're gaining more weight. And, you know, then we have abnormal blood glucose levels later on.
Questions for Sadia Fatima. Let me check the question and answer box. No, there is no question for you, Sadia. And just one final query which I had is how do you intend to take your epigenetic study forward in terms of improving the health status in the LMIC population, like Pakistan, or how that can help our other neighboring countries to replicate the same findings or take your findings into that part of the population?
Right. So first and foremost would be to have, a bigger project in terms of collaboration. So the LMICs, we can have a collaborative project where we can have bigger sample size. We can maybe start from preconception till post-birth, and we can pool our genetic data and then find out what's the status here. Because South Asian genetic pool is very different as compared to the genetic pool that is available at the GWAS studies and, you know, all the searches that we do in terms of SNP data as well as in terms of presence or absence of a protein or a promoter area. So I think we can take it forward in terms of having an international collaboration, maybe working on a grant together, maybe pooling our samples, pooling our resources and, you know, expertise, and also that is way forward that can improve one aspect of our findings.
Okay, great, Sadia. So we have one more question from Yajnik. Yajnik is actually from Pune, and their team has worked tremendously along this line of epigenetics and preconception and in the population of diabetics. So his question is, what's the average birth weight in Pakistan and in GDM pregnancies?
Right. So average birth weight, again, it's got a range. So 6 to 7 pounds is an average birth weight of a normal glucose tolerant pregnancy that we see. Dr. Noor can correct me if I'm wrong there, because he sees these patients regularly. Whereas in GDM, we've seen as much as 12 pounds or 14 pounds babies being born. So it's between a range of 9 to 14 up till that. So that's one thing as well that's happening. So there's a huge difference between NGT and GDM babies in terms of birth weight.
Yeah, so the average birth weight is around 2.6 to 2.8 kg, right, under normal circumstances. And of course, for GDM, it ranges from between 3.7 to 4.2 kg, right? So that's what the average weight is about. Any other questions for Sadia? I don't see any questions here in the chat box. So with that, we conclude today's session for the Doha Worldwide webinar for December, and it's the last session for this year. And we hope to meet all of you very soon next year, 2023. Till then, on the behalf of the International Society for the Doha, myself as the Executive Secretary, our communication team, from our President, on behalf of our President and the administration team, I wish you all in advance Merry Christmas and Happy New Year, and have happy holidays. And those who will be traveling across during the break, do have a safe journey. Thank you very much, and take care and have a good day ahead.